Good afternoon and welcome to today's webinar, Echocardiography Assessment of the Right Ventricle. My name is Kelly Baer and I'm the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will be monitoring questions throughout the presentation, and we'll try to answer as many of them as possible during the Q&A period. Also on the left side of your screen is the Resources tab. Click this tab for links to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during the course of this webinar, you may click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed you automatically at the end of the session. To be eligible for the ASE CEU credit, you must be registered, logged into this webinar, then complete the survey. The survey will open automatically at the conclusion of the live session and be available from the IAC Pro Libraries website for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. This presentation is being recorded and will be posted at a later time for on-demand viewing. This webinar is a joint presentation of IAC and the American Society of Echocardiography. And now I'd like to introduce today's guest presenters. With us today are Dr. Geoffrey Te Jao and Pamela Burgess, both from the Cardiac Ultrasound and Stress Testing Lab at Wake Forest University Baptist Medical Center in Winston-Salem, North Carolina. Dr. Jao is the Advanced Heart Failure Transplant Cardiologist and an Assistant Professor at Wake Forest Baptist Health, board certified in internal medicine, cardiovascular diseases, and adult echo. Pamela Burgess is the Clinical Manager of the Cardiac Ultrasound and Stress Testing Lab. She serves on the IAC Echocardiography Board of Directors representing SDMS, is an application reviewer for IAC, and brings over 25 years' experience as a sonographer. Both are true experts in the field. With that said, I will now turn the webinar over to Dr. Geoffrey Te Jao. Doctor?
Good afternoon, ladies and gentlemen. I'd like to take this opportunity to thank the IAC for the invitation and privilege to talk to a group of individuals who are interested in echocardiographic RV assessment. So I have no disclosures relevant to this talk. The flow of this presentation will be, number one, to discuss the clinical evidence as to why we should care about the right ventricle. And then as we proceed, we go to the meat of the discussion, which is echocardiographic assessment of the right ventricle. And then we'll end up with a few cases to discuss to tie what we just learned and apply it in real cases. So without much ado, let's proceed. So why does the right ventricle matter? We have known from as early as in the 1990s that preserved RV function actually makes a difference in terms of survival and event-free survival in patients with advanced heart failure. This was a study composed of 67 patients who were referred for heart transplantation in Mass General, and during that time they were trying to look for parameters that would predict outcomes. They used exercise-limited cardiopulmonary exercise test, symptom-limited cardiopulmonary exercise test, as well as rest and exercise first-pass radionuclide ventriculography. And the patient population that they had had a mean age of 51. 58% had New York Heart Class 3 symptoms. 18% had New York Heart Class 4, and the rest New York Heart Class 3. The average left ventricular ejection fraction of this patient cohort was 22%. Their VO2 peak was 11.8 milliliters per kilogram per minute, which was 38% predicted, and their median duration of the follow-up was 58 weeks. There were 16 deaths in this study, 14 of whom died from sudden cardiac death and 2 from progressive heart failure. The major finding of the study is, as you can see on screen, that preserved right ventricular function is a prediction of overall survival and event-free survival in patients with advanced heart failure. This study also showed that right ventricular ejection fraction at rest and or with exercise predicts functional capacity as assessed by peak VO2 during exercise. So this was a novel finding. 3 years later, a paper came out. A group of investigators from FANS asked the question, would these same findings apply to moderate heart failure patients? So what do they mean by moderate heart failure patients? These were individuals who had chronic systolic heart failure who were stable in the outpatient setting. They need not be hospitalized recently, no MI, not on inotropes, and not listed for transplantation, and had to be on stable medications. Note that in 1998, included in the study, there were only 17% of the patients who were on beta blockers. So they recruited 205 patients, and they did exactly the same study design, symptom-limited cardiopulmonary exercise stress test, rest and stress first-pass radionuclide ventriculography, and here are the profile of these patients. 68% of them had New York Heart Class 2 symptoms, and 32% had New York Heart Class 3. The average age was 54. Left ventricular ejection fraction was 29%. The VO2 was 16.2, much less sick compared to the earlier data that I presented. The median follow-up this time around was 755 days. During the wait time, there were 44 cardiac deaths, 3 non-cardiac deaths, and 15 had to go for heart transplantation with 1 lost to follow-up. The major finding of this trial, the total population survival curve from cardiovascular mortality and urgent transplantation is on the right screen. At 1 year, the total study population had a survival of 90%, and at 2 years, 81%. But if the group were to be stratified according to their right ventricular ejection fraction, on the left of screen, then one can see that preserved ejection fraction patients did so much better. In fact, at 1 year, in contrast to the total patient survival of the total cohort, which was 90%, the patients who had RV ejection fraction of under 25% had only a survival of 80%. 2-year survival for the total cohort was 81%, as mentioned. For the subgroup of patients with an RVEF of 25%, their survival was only 59% in this trial. So both of these studies highlight the fact that heart failure is a progressive disease. How about we fast forward to a more modern patient cohort? These are patients with advanced heart failure who are waiting for transplant and was listed for transplant, but in the process needed an LVAD, received an LVAD in order to bridge to transplantation. This study is the HeartMate-2 Bridge to Transplant trial, which was a multi-center prospective clinical trial, initially of 133 heart failure patients. The primary outcomes were the percent of patients at 6 months who had heart transplant, cardiac recovery, or had ongoing mechanical support while remaining eligible for heart transplantation. Well, the slide should say heart RV failure predicts post-LVAD mortality. So how did they define RV failure? These are patients who received right ventricular assist device or who have received inotropic support more than 14 days after receiving an LVAD, or late start of an inotrope 14 days after an LVAD was implanted. The outcomes, they found that RV failure, in contrast to those who have preserved RV function, did so much poorly even at the 30-day mark, at the 60-day mark, and more so at 1 year. They then retrospectively and went back and looked at all the LVAD, patients who had received LVAD as bridge to transplant, and came up with and tried to look at the incidence of RV failure and what are some of the risk factors that contribute to RV failure. What they found was that 20% of patients developed RV failure post-LVAD implantation during this period of time when the study was done. 6% had RVAD implanted, 7% needed extension of inotropic support, extended inotropic support, and 7% had late inotropic support. The major predictors from this study for RV failure were pre-op mechanical ventilation, CVP to pulmonary capillary wedge ratio of greater than 0.63, and BUN greater than 39. The take-home points from these clinical studies is that heart failure is a progressive disease, as was mentioned earlier, and so if you find yourself scanning a patient with at least moderate to severe LV dysfunction, then it would make your advanced heart failure cardiologist in general very happy if you objectively and quantitatively assess the right ventricle function as much as possible. The next part of my talk would pertain to the anatomy and physiology of the right ventricle that would become very relevant as we talk about why we measure certain RV measurements on echocardiogram. So when we take a look at this picture, the differences are more evident compared to the similarities, so let me start with the similarities. Both ventricles are covered and share the same pericardium. They share the interventricular septum as well. Now, the right ventricle is crescentic in shape and almost, as a colleague of mine would say, looks like a banana lying on the side. It is much less muscular. It is 1/6 the mass of the left ventricle. Now, it is made up of two muscle layers. The deeper muscle layer are longitudinal fibers that then connect from the base towards the apex. And the more superficial fiber is made up of the circumferential layers that then traverses the AV groove and then goes towards the left ventricle and join their superficial fibers. The superficial fibers of the left ventricle are obliquely oriented and are three layers: the same innermost longitudinal fibers, middle layer circumferential, and the superficial layer that is oblique. Now, the oblique fibers give the left ventricle the ability to twist as they eject blood from the left ventricle. The right ventricle does not have the capacity. Now, the normal RV function, about 80% of normal RV function is actually movement of the RV from the base towards the apex. That is the reason why we check the TAPSE or the S prime in most of these cases. Now, the anatomic differences reflect the distinct physiologic functions of the right ventricle. The RV functions to maintain a low systemic venous pressure, provide pulmonary circulation, and adequately fill the left ventricle. It is also exposed to a high capacitance, low resistance vessel, vasculature, which is the pulmonary circulation, in contrast to the left ventricle. Now, for that reason, the RV being, small in size, less muscular, it does not tolerate high afterload very well. This is an experiment of a canine heart, wherein they cut out the right ventricle and placed and sewed in a pericardial patch and clamped it. So on the screen right, as you can see, even without any right ventricle present, LV contraction, if it's normal, leads to some degree of right ventricular pressure generation. This is partly because they share some fibers, but also the interventricular septum. Now, what happens is, as the right ventricle, or the neo-right ventricle, starts getting volume loaded, we can see that the RV stroke volume progressively decreased to nil, and the LV function at this point is also progressively decreasing. What can explain this phenomenon well is by this cartoon that I found on the web. Now, on the left of the screen is a normal RV diagram. As the right ventricle progressively gets loaded with volume, what happens is the pericardium prevents it from expanding more. As a result, with continued volume loading, the right ventricle would have developed high enough pressure to push the interventricular septum towards the LV, decreasing the LV size, thereby decreasing the LV stroke volume. Focusing on the right of screen, figure B, one can see that the RV, in contrast to the LV, tolerates pressure afterload very poorly. On the x-axis, we can see that with very little changes in mean PA pressures, the RV stroke work index significantly drops. While the same holds true for the left ventricle, it is not as dramatic. These are the anatomic and physiologic constructs for the basis of our echocardiographic assessments, which will be given by Pamela Burgess.
Okay, thank you everyone for joining our webinar today. My portion of the presentation will include the echocardiographic assessment of the right ventricle. We as sonographers and echocardiographers have always focused on the left ventricle, so a lot of the measurements I'm going to be going over are measurements that maybe in the past you performed on the left ventricle, but now we're adapting them to the right ventricle. The views are essentially going to be a review of what we do already, so that's included in our basic protocol. So with the measurements, just look at this as an extension of your basic protocol for a right heart patient. So the right heart imaging windows that we use, of course, we use all the ones that we normally acquire during our basic protocol here. I didn't put these in order because I felt like the apical four-chamber is the most important. It's where we do the majority of our measurements from. So, and we can also see the entire right ventricle from this approach as well. And we all know as sonographers that not every patient has all these views, so we may have to adapt to certain views and not be able to gather all the images that we have listed here. So each view contributes something to the right ventricular protocol that we're going to be talking about today. So again, parasternal long axis view, RV Inflow view, which is a required IAC view, is included in this, short axis, and even the subcostal view. So we'll look at each one of these individually here. Parasternal long axis is, of course, the first view that we always obtain when doing an echocardiogram, and we see the right ventricular proximal outflow tract here, this, and we as sonographers can automatically, get a good idea of the size of the right ventricle, the right ventricular function here. We can even, we'll show you about making a measurement from this approach here as well. With just a slight tilt of the transducer, we can go into the right ventricular inflow view, which again, we can tell something about the size and the function of the right ventricle. We can also see the posterior leaflet of the tricuspid valve here, which is the only view that we can visualize that from. And we get an estimate of the right atrial size. We can also utilize color Doppler, spectral Doppler, and obtain TR gradients. And, we need several views for that as well, so we can become as parallel as possible when obtaining our gradients and get the highest gradient. So when we move to the apical view, I would like to just take some time here and talk about an apical 4-chamber view when we're looking at the right ventricle. If you notice on the top right here, the diagram that looks to be in a short axis view, you can see the 3 planes that we could possibly go through when obtaining an apical 4-chamber view. Each of these are over to the left side of the screen as well. And if you look at them, you can, through the planes there, the short axis, you can see the different size, the different areas of the right ventricle that we're intersecting with these different apical 4-chamber views. And if you also notice at the bottom right, you can see the difference from these different planes, how different the measurement can be on the same patient here. So the one in the middle is one I'd really like to talk to because it's one that I feel is important to do with a right heart assessment, and that's a focused right ventricular view, where we are still pretty much right over the apex of the left ventricle, but we can just slightly angulate a little bit and bring in the right ventricular free wall a little nicer there, so we can assess the right ventricular function there as well. So, and you can see below the difference and normal apical 4-chamber makes with that. So the focus view actually helps us image the right ventricle better and assess the function there as well. Okay, so here's just a couple examples of a focused right ventricular view from the apical 4-chamber view. You can see how we could easily assess the right ventricle here all the way from the base to the apex. We can see the right ventricular free wall there. We can make measurements of the right ventricle from this approach. And do a number of measurements from here as well. Okay, so when we measure the right heart, we do this mainly from the right ventricular focused apical 4-chamber view. We would want to make sure that we can see the crux and the apex of the right ventricle in this view, and trying not to foreshorten the apex. We're looking for the maximum diameter, or during end diastole is when we would like to make our measurements. We'll make one at the base of the heart, one at the mid-ventricle, and we can also measure the length of the right ventricle there as well. Next slide here I'm going to show is a case example with the one on the left being the focused right ventricular view, and you can see how we have measured at the base of the right ventricle, mid-ventricular, and then again with the length of the right ventricle. And we would measure that from the tricuspid annulus down to the apex of the right ventricle, and we would do this at end diastole as well. The view over on the right, of course, is parasternal long axis, where we've also measured the right ventricle here, and we would again do that from the at end diastole and measure our right ventricular free wall down to the interventricular septum. And this would be more of a right ventricular outflow tract measurement there as well, or proximal right ventricular outflow. Okay, so when we measure the right ventricular wall thickness, this is a measurement that is probably best done from the subcostal view. It can be done from parasternal long axis view. We would want to measure this during diastole. You can either use 2D or M mode to make this measurement. I would say that it helps a lot if you zoom up on this area. The thickness, if it's greater than 5 millimeters, indicates that there might be right ventricular hypertrophy, and it may suggest right ventricular pressure overload as well. So here's a subcostal view. You can see how the sonographer has very nicely used the liver as a window here to image the heart. It's a subcostal 4-chamber view, and you can see where they've made the measurement there. If I can get this cursor to move right over it there. You can see where the right ventricular free wall has been measured there. It's measured again right on the QRS, and this one measures 0.9 centimeters, which is would be considered right ventricular hypertrophy for this patient. Okay, so next we'll look at measuring the inferior vena cava. Of course, we'll do this from a subcostal view. And remembering that we do encounter patients where we can't image the subcostal view all the time from epigastric gas or, whatever they may have living in that area that causes us to obscure the area around the IVC. So at times we may have to alter this view. We may have to go around on their rib cage around laterally and project in through the liver that way to see the IVC. But just to let you know that there are alternatives to scanning right through the epigastric area. We like to measure at the level of the hepatic vein, and the IVC is normally less than 2.1 centimeters. And while we're there, we also look to see if the IVC collapses with a sniff. And we look to make sure that it collapses greater than 50%. This can also be looked at through M mode if you can't really tell how much it's collapsing, whatever. So anything over an IVC measuring greater than 2.1 centimeters would be considered an enlarged IVC. And we'll talk more about this in a few minutes when we are assessing the right atrial pressure. So here's two examples of where an IVC has been measured, the one on the left being a normal IVC measuring about 1.4 centimeters, and the one on the right is more of a dilated IVC, one that you like to get so they're easily measured there, and this one measures about 2.4, so it is abnormally large there. You can see how the sonographer has nicely measured right around the insertion of the hepatic vein there as well. Okay, so right atrial measurements, there's a couple ways we can do this. We can do an area trace, or we can just do the dimensions across the right atrium. First of all, let's talk about the right atrial area. We'll do this from an apical four-chamber view, and we'll trace from the medial tricuspid annulus to the opposite annulus or to the lateral annulus, and we'll do this at end systole. Anything greater than 8 centimeters square is considered right atrial enlargement. And you can actually, on most any ultrasound machine, go into your generic area package and do this if you don't have this measurement set up in your machine. The dimension measurement that we can do, our right atrial major dimension, is just actually the length of the atrium. So we would measure from the tricuspid valve annulus back to the back wall of the atrium. And our right atrial minor dimension would be just across the right atrium itself. So for the major dimension, anything greater than 53 millimeters would be considered enlarged. Minor dimension, anything greater than 44 millimeters would be considered enlargement. So here's an example where we've actually done both of these. You can see the right atrial area has been traced out here. So we started at the medial annulus of the tricuspid valve, and we traced around the interatrial septum, back wall of the atrium, around to the lateral tricuspid valve annulus. We do not draw up through the leaflets there. We just stop at the annulus and let the machine just kind of bring the cursor over and connect with the other medial area there. So we've also included the major dimension there. You can see where we've measured from the annulus of the tricuspid valve back to the back wall of the right atrium, and then from side to side for the minor dimension there. Okay, so now we're going to move more into the measurements that will help assess the right ventricular systolic function. You can see that there are several of them that we use. And they all, show us a variety of things here from a different approach. So we'll start out with TAPSE. And what TAPSE stands for is Tricuspid Annular Plane Systolic Excursion. And this is an easy-to-do measurement. When we do this measurement, what we're looking at is the right ventricular longitudinal function here. We do this from an apical four-chamber view. We utilize M mode, and we just put our M mode cursor through the tricuspid lateral annulus while trying to be as perpendicular as possible to the annulus. And this measures the longitudinal motion of the annulus that's toward the apex during systole. TAPSE, anything less than 16 millimeters, indicates RV systolic dysfunction. Okay, so here's a couple examples of TAPSEs that were done. And remember I said we like to be as perpendicular to the tricuspid valve annulus as possible. The one on the left is angled slightly. And so if it's angled slightly, we're not going to get as high of an excursion as if we were not angled. So two different patients here, but you can see the difference in where the cursor lies across the annulus there. So the one on the right is a normal TAPSE. And also what we like to do here, and it's a little hard, if you look to the image in the bottom left, you can see how the sonographer there has found a line and then put one cursor there and then bring the second cursor up as your eyes follow the systolic excursion there to make the measurement. So what you try and do is just follow that same line up so that you accurately measure the TAPSE there. Okay, here's an abnormal TAPSE, and you probably can just look at this one and tell that the excursion is not as great as the ones we were just looking at. And this one, the TAPSE measured 11 millimeters, which was in line and correlated well with this person's RV dysfunction. Okay, so S prime is the next thing we're going to do. We do this with tissue Doppler, very, very similar to what we do with the left ventricle. It's an easy measurement, it's reliable, and it's easily reproducible. We take care in properly aligning the Doppler cursor with the annulus. Again, this is very important. It may mean that you slide the transducer ever slightly over the right ventricle just to line this up, but just be careful not to do this from an exaggerated angle. So our S prime velocity, if it's less than 10 centimeters per second, suggests that there's RV systolic dysfunction. And here's a couple examples of where we've done S primes. You know, we as sonographers doing tissue Doppler on the left side of the heart, we're always concerned with everything below the baseline, looking at that, the filling there. So on this one, we're looking at the systolic function. So we're looking at the waveform above the baseline, okay? And so we're just watching that annulus move toward the apex during systole. So that's how we get this measurement here. And so we said anything less than 10 is abnormal. So you can see the one on the left side of the screen actually is the scale set at 10. So when you acquire these, you need to be real sure that you've got your baseline down and know that you're looking at the waveform above the baseline here. But we can easily see that this one is above 10, so it's a normal one. The one on the right is an abnormal one. You can see they've got the angle fairly well set up there with the tricuspid annulus. And our scale there, you can see 10 on the far right side, and the measurement was less than 10 on this one. So this was an abnormal S prime there, which also correlated with the RV dysfunction on this patient. The next measurement we're going to talk about is right ventricular fractional area change. And this is done from a 2D approach. We pretty much get right over the right ventricle, making sure that we can view the entire right ventricle, and we carefully trace the right ventricular free wall, drawing through any trabeculations. So you wouldn't want to draw around the trabeculations. You would want to draw through them, much like what we do when we're doing a trace for an EF on the left side of the heart. So we use the equation below, where it's right ventricular end-diastolic area. We acquire that and trace that out, plug that into that part of the equation. Then we trace out in the same cardiac cycle there the systolic RV in systolic area, and then we divide that by our right ventricular end-diastolic area and multiply it by 100 to get a percentage there. So anything less than 35% is going to be considered RV systolic dysfunction. This is a relatively easy measurement to make if you can see the right ventricle. okay? Sometimes that's very difficult. We do difficult patients too. Dr. House can send us difficult patients and where it's really hard to see much of any of the right ventricle, much less be able to trace it out. So, just try and optimize your image as much as possible. Roll your patient further over on the left side to help image the right ventricle better. And, even if you are really, really wanting to get this and can't see the right ventricle well or left ventricle and you're giving the patient contrast, you may even try and, as the contrast fades out of the right side of the heart, freeze you a diastolic and a systolic frame and then trace them out later. That could, I think, be beneficial in making this measurement because sometimes it's very difficult to see the walls and where to actually measure these. So just make sure that you do it, on the same complex there. You do your diastolic and then your systolic. So, okay. So RIMP is going to be the next measurement we talk about, and probably some of you have done LIMPs, and so now we're going to talk about RIMPs. And RIMP is just the right index of myocardial performance. So it's an index of global right ventricular function, okay? So RV dysfunction in these people would be a RIMP of greater than 0.40, and that's done with pulse Doppler because you can do this with tissue Doppler as well. RIMP is something that we really don't include in our right heart protocol, but I know some people may do this. So what you do to obtain this measurement is you just do tricuspid valve inflow and make sure that you spread your Doppler signal out both, vertically and horizontally, and also do this with your right ventricular ejection time, and this would be done with pulse Doppler. Right on the tricuspid valve inflow and right in the right ventricular outflow tract. Remember, this can be falsely low with elevated right atrial pressures, which means there's a decrease in the isovolumic relaxation time. Okay, so here's a diagram that shows the tricuspid valve inflow on top. So if we measure from tricuspid valve closure to tricuspid valve opening, and you can see now the importance of spreading the signal out so you can make your measurements a little easier. And if you notice the equation, the top right, so we take our tricuspid valve closure to opening time, and we subtract from that our right ventricular ejection time, which we measure through our right ventricular outflow tract, just from the onset to closure of the pulmonic valve there. Subtract that, and then divide by that, we would have our RIMP. Okay, the next thing we're going to talk about is right ventricular strain. I know we get to do a lot of left ventricular strain on our chemotherapy patients, so now we're introducing strain into the right side of the heart. I don't think any equipment companies, and I could be wrong here, that really have right ventricular strain. I think there is one that you can do after the fact on a different type software. But so right ventricular strain, what we're going to be looking at is shortening or the percentage of change in length over the systolic event. So because it's going to get shorter, we're going to have this number will be displayed as a negative value. Our right ventricular strain values, although there's not a lot published out there right now, they're going to be similar to our left ventricular strains. So essentially what we're going to do is we're going to fool our system, our ultrasound system calculation package here with right ventricular strain and act like we're doing a left ventricular strain, but we're going to be doing it on the right ventricle. So issues with strain, same as they are on the left side of the heart. Image quality is a huge issue for us. If we have poor signal-to-noise ratio, we're going to have trouble with the strain. There's also going to be variability due to the placement of our sample volume, so we need to carefully place that. And also remember, too, when doing left ventricular strain, we have 3 views. Here we only have 1 view with right ventricular strain. So how we're going to do our right ventricular strain is we're going to obtain an apical 4-chamber RV focus view. We're going to ensure that our frame rate is adequate for our machine, and we're going to contain at least 3 cardiac cycles. We're going to place the cursors at the basal area, the right ventricular free wall, and again over at the medial annulus there at the interventricular septum, and then the third one at the apex. Before accepting the strain, we're going to block out the interventricular septum segments there, so we do not include that in our average. So you can see how we've done this one. Again, this is an apical 4-chamber view where we could very nicely see the right ventricle, and I know this is not always the case, but you can see in the bottom left how we've blocked out the interventricular septum and just allowed the strain over on the right ventricular free wall. Again, here our numbers are fairly high negative numbers, and again, we would utilize the same numbers as we do for left ventricular strain here. Okay, so pulmonary artery systolic pressure is something we've done for years as sonographers, so I'm not going to spend a lot of time on this, but just remember that we need to try and get our highest peak velocity over our tricuspid gradient there, and also we need to pay a lot of attention looking at the IVC, making measurements, and how well that collapses with a sniff. So this slide just kind of gives you how to estimate your right atrial pressure. You can see that you'll, again, need to look at the size. You'll need to look at the inspiratory collapse on these patients. Again, if your eye can't visualize what's, less than 50% or greater than 50%, you can use M mode to help with that and actually make the measurements there. Okay, so hepatic vein flow here is something else that we look at when we're doing a right heart assessment. Again, I've picked one that's very nicely seen, dilated. I know that they don't occur like this every day. Sometimes they're very difficult. But if you really work on these, if you look for the hepatic vein to be draining into the IVC and then kind of lay it out so you get the longest axis of it, you'll be fairly successful. You may need to drop down your color a little bit, the velocity scale a little bit to see that. But just here, this one, you can notice that you see flow reversal back into the hepatic vein, which is going to be important when we look at what the spectral Doppler looks like on this patient. So the left is a normal, where the majority of the signal is below the baseline. We know that we're looking at the hepatic vein, which is moving away from the transducer here, draining into the inferior vena cava. So we would expect the majority of our signal to be below the baseline here. We have a much higher systolic component than diastolic component, and then our atrial reversal there. Over on the right side, this is a patient that we were just looking at the color flow through the hepatic vein, and you can see where we have systolic flow reversal, which is significant on this patient, and also an accentuated diastolic component on this patient as well. So I would expect this patient to have significant tricuspid regurgitation. Okay.
All right, Pam, that was great. So we're going to try to in the next 5 to 10 minutes, try to summarize what we just learned and apply them with cases, actual patient cases. So, first case, the question is does this patient have HFpEF, heart failure with preserved ejection fraction, or pulmonary hypertension, or both? So this is a 66-year-old, very pleasant lady. She's morbidly obese, and when seen in the hospital, really in decompensated state, New York Heart Class 4 symptoms, progressively worsening over the past 6 months. She's carried with her the diagnosis of heart failure with preserved ejection fraction for about 3 years now, and she was also told that she has pulmonary hypertension from portal pulmonary hypertension, diagnosis made at an outside facility. She had obstructive sleep apnea, but does not use CPAP regularly, hypertension and diabetes. Over the past 6 months, she had repeated heart failure hospitalizations. Severe exertional intolerance was evident. Taking a shower would take her, forever. and abdomen was becoming more distended. Her legs were more swollen, and she had worsening renal function with this. Throughout her hospitalizations, volume status was felt to be difficult to determine, and diuresis was half-hearted because as they tried to diurese her, renal function would get worse. She's on sildenafil, digoxin, Lasix, and spironolactone when we saw her, and the following are her echocardiographic pictures. Now, in this parasternal views, one can see that on the screen left, the right ventricle is quite generous, and also mentioned by Pam nicely earlier was that this is a view that one can take a look at and estimate the right ventricular wall thickness. Now, in obese patients, subcostal views may be a challenge, and in this case, the subcostal view was inadequately obtained. So, based on this, RVOT is enlarged approximately, and RV may be thick. On the screen right, one can see that there is flattening of the interventricular septum and a relatively large right ventricle as well. Now, mind you, this echocardiogram was obtained after removing 10 liters of fluid from this patient already, but still, as you can see, the pulmonary pressures remain very high. Apical four-chamber view of this patient is very, very frightening. Her right ventricle is apex forming. It is, in fact, much larger than the left ventricle. This is not a Mayo format echocardiogram. Looking at the right, making the measurements, one can see that the basal measurements exceeded 4.2 centimeters, which is indicative of RV enlargement. In the mid-right ventricle, the measurement was 4.72, and that's more than 3.5, which is indicative of RV enlargement. Now, the LV inflow pattern, the mitral valve inflow pattern shows an impaired relaxation, and that will be important as we go through the case. This is the TAPSE. Now, the measurement of the TAPSE is not ideal in this case, but if we measure it further down and up to the top, its distance is about 1.0 centimeters, and on the screen right is the S prime. S prime is about 9.94 centimeters per second, both indicating RV dysfunction. The peak gradient, this patient had moderate, at least moderate tricuspid regurgitation. I would say moderate to severe tricuspid regurgitation, and the TR gradient was 49 millimeters of mercury. Her IVC, surprisingly, was measured 2.13 and was given a right atrial pressure of 10. Her hepatic vein flow showed classic systolic reversal, indicative of her tricuspid regurgitation. So, correlating the echo with the right heart cath done on the same day, one can see that her right atrial pressure was actually markedly elevated at 26. Her PA pressure was 62/35 with a mean pressure of 44. Now, if one takes a look at the estimate using echo, her RVSP plus the right atrial pressure actually is pretty close to 62. It was estimated around 59. Her wedge was 13 on right heart cath. Now, if you remember, her LV mitral inflow pattern showed impaired relaxation, which should indicate normal left-sided filling pressures. Her mixed venous was markedly reduced, and her pulmonary vascular resistance is 7.8. A nitric oxide challenge was given, and she did not respond to significantly to NO challenge. Now, there are several clues on this echocardiogram that are important. Number one, there is a pulmonary hypertension that would be seen as indicated by the septal flattening. The RV is enlarged. There is pericardial effusion. In patients with pericardial effusion and concomitant pulmonary hypertension, that is a very worrisome sign and indicates severe pulmonary hypertension. Of course, she has New York Heart Class 4 symptoms. That also points toward severe pulmonary hypertension. Now, this is the reason why I don't like to give assign a particular value to say mild, moderate, or severe. As you can see on this graph, the red is the pulmonary vascular resistance, the green is the PA pressure, and the purple, if it shows well on your screen, is the cardiac output. Now, if we look at this point where the green and the purple overlap, let's take that as a sample of a PA pressure. The cardiac output is still intact, and yet the pulmonary artery pressure at this point would be similar compared to this point where the pointer is, but the difference is the cardiac output is now markedly reduced. So I think our patient's trajectory is actually on this far screen right, wherein her cardiac output was reduced. I forgot to mention to you that on that echo, her stroke volume index was also markedly reduced at 19.8 milliliters per square meter. So this patient had a severe pulmonary arterial hypertension, normal left-sided filling pressures, therefore not likely to be HFpEF, although one must say that this is in the setting of resting hemodynamics. So she was given continuous oxygen, continued CPAP use of at least 6 hours per night. We increased the sildenafil dose as much as she could tolerate, and more aggressive diuresis continued digoxin. Her renal function actually improved with these interventions. Unfortunately, insurance will not cover IV Parasternal in this case. She continues to follow up in clinic and had somewhat improved symptoms, but she's not quite ready to move forward with her care yet. Now, we have one more case, but cognizant of the time limitation we have, so we will stop right here and welcome any questions.
Okay. Thank you, Dr. Howe. At this time, we will begin the Q&A session. From IAC Echo, I'd like to introduce our senior clinical specialists, Sandy DePetris and Sue Jensen. Sandy and Sue will be assisting the Q&A session today. Sandy, would you like to start us off?
Sure, Kelly. Dr. Howe, Jessica asks, why use the RA dimensions by 2D or M mode rather than volume measurements for this type of assessment?
Sorry, you were breaking up. Can you repeat the question?
Sure. Why should you use RA linear dimensions rather than volumes for this assessment?
It should be, an area. So the problem with RA assessment is that you get all of them in a apical 4-chamber view, right? So only in that view. So you get the area length method to estimate what your right atrial size is. So you can get the length and the width across, but also a right atrial volume estimation once you do that. And we take all of that into consideration.
Okay, this is Sue. I have a question from Jacob. He says for mechanically supported patients, i.e. RVAD, LVAD, ECMO, which RV assessment parameter has been shown to be the most reproducible and sensitive?
That's a very interesting question and must come from an LVAD center. The RV assessment that we like to use, that's my favorite, is the TAPSE. Now, in preoperative patients, that TAPSE of less than 0.75 has been shown by one single center trial to predict RV failure postoperatively. Now, there has been more recently data about that this TAPSE of greater than 16 millimeters may not apply to post-cardiotomy patients. In fact, what has happened is the RV contractile pattern postoperatively differs from that preoperatively, and this may be related to the cardiopulmonary bypass time that they spent in the OR, or the amount of pericardium that may be removed. Remember that the right ventricle contracts from the base to the apex normally, and it seems that postoperatively, and especially if a large amount of the pericardium is removed, the pattern of 80% contribution of longitudinal shortening is no longer true. So I do not base my assessment of the RV on one parameter, but instead look at it globally. And if I have hemodynamic numbers available, that will be great in coming up with clinical decisions.
Okay. Gerson asks, has 3D echo enabled you to get additional information or views of the RV that has added to your assessment of the RV function?
3D echo is most certainly described. We don't routinely do that here in our center, predominantly because it's just time-consuming, and it requires a very good visualization of that right ventricle. So if we have good visualization of the RV, we'll get TAPSE, we'll get S prime, and we have the time, fractional area change, and the RV strain. I think due to that limitation, most of the time we don't necessarily do 3D assessment of the right ventricular function.
Okay, Josephine would like to know what measurements would be utilized if an LV-RV ratio is requested.
So, there has been 2 articles that look at that. The RV ratio, I think, would be obtained from the base of the apical 4-chamber view, and then the LV ratio would be at the LV-IDD at the parasternal long axis view. So that's the RV-LV ratio, both obtained during ASLE. There was one additional paper that looked at I think that would be actually more strong, and that's what I would do. There are more certainly data that points towards the utility of this in predicting RV dysfunction post-LVAD.
I have an interesting question. Nazmi asks, is it still best to assess the RV assessment visually, or do you think that all of these measurements are better than the visual assessment?
That's a question that my fellows ask me all the time. Why do you take this trouble? Well, let me tell you this. We usually say qualitative assessment, RV size, for instance, would be perfect. In my world, the LV is so huge, and usually we say that the RV should be 2/3 the size of the LV. And if it is as big as the LV, then it's at least moderately enlarged. And if it's apex hugging, then you have severe RV dilatation. Well, in someone whose LV is the size of my fist, that criteria itself would be very difficult to apply. And so I would say that, we use clinical gestalt. We also look at the echocardiogram, look at globally, look at fractional area change if your S prime doesn't quite make sense, and make sure that your measurements were actually obtained correctly and apply this. I would still advocate for quantitative assessment of the RV function as much as possible, especially if these patients have advanced heart failure options down the road. We would take these all into consideration together with hemodynamic measurements.
I have one last quick question from Jill, and she just wants to know, do you quantitate RV enlargement as mild, moderate, and severe?
Yes, we do. It is very interesting. This is where the art of interpretation comes in. How do I do this? So first of all, I do the measurements of, as Pam has described, at the base of the RV, at the level of the tricuspid annulus, mid-ventricular, and the longitudinal assessment. And then, if it is enlarged, I then apply what I just told you about. If it is apex hugging, then the RV and the LV is not that huge, then that's probably severely enlarged right ventricle, as was shown in the first case that I featured. She had severe pulmonary hypertension, RV was apex hugging, the LV looks small. So there is no question. The moderate and mild category is more subjective, I think, in my opinion.
One thing to keep in mind, too, that as we look at LV measurements to RV measurements, a lot of our left-sided measurements are indexed to the patient's height and weight. These right-sided measurements, not so much. So that could also come into play with some of these patients.
Okay. Well, thanks again, everyone, and we would like to extend a special thanks to our presenters, Dr. Howe and Pam Burgess, and please feel free to contact the IAC Echo with any additional questions you may have, and feel free to download the full PowerPoint under the Resources tab. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of this live session and also be available from the IAC Pro Libraries website for 3 business days. In the upper left, you'll click on My Webinars, look for the title of this session, Echocardiography Assessment of the Right Ventricle. Beneath this title, you will see the link Take Evaluation. Click this link to complete the survey. Your certificate can then be accessed and printed from the very next screen and any time thereafter through a new link on the My Webinars page called View Certificate. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you all for joining us today and appreciate your participation.